All right. Hello and welcome again to another Down Fracture podcast, a podcast for talking jaws. Down Fracture Podcast at gmail.com. We do again appreciate the correspondence. Again, if you're a patient, we may not respond. And if you're a provider, please list your byline, just because that's that's the intended audience, I guess I would say. Not that we're being mean or don't like you. Um, Sam, what's up, man?
Not much. It's good to see you. It's kind of fall time. What are you doing for the holiday?
Which one?
Thanksgiving. Bunch of people over?
No, we're going to travel, go see some people, and
Great.
then staying for Christmas. What about you?
Yeah, pretty much the same. Um, I like sticking around for Thanksgiving and then kind of traveling outside of the actual holiday travel season. So catching it January or February or something like that. So uh yeah, it's crazy. It's the end of the year. Now that we've crossed over our 1 year anniversary, we're on to year two. So how are we going to start this year out?
I'd say let's try it with a bang.
Yeah, I think
I
it'd
think
be
it's
great.
better than non-bang king.
I'm not going anywhere near that. We were talking before this, trying to come up with a topic because next week we have a good episode planned. This week we kind of overlooked a little, but we were looking at topics suggested, and maxillary interferences was the one that I thought we settled on.
Yeah, I think that's what we settled on after last week's episode. We did get some good feedback about last week's episode, and we got some anniversary gifts and emails, which was nice. We do want to make sure that we're putting the plug in for the ACOM's winter meeting, that we are doing a live broadcast of this podcast there, whatever that means.
Yes,
Um,
winter meeting ACOMs, Telluride in February. So I think the early registration's changing. Maybe you still got a month, but I know February can be far away, but it's a good time to look at um,
yeah,
planning
especially if you want to
tickets,
book a
getting
room. Booking
hotel
rooms is getting
rooms.
trickier at the moment. I don't know if
Yep.
you've gotten that far in your process. Probably not, if I had to
I'm
guess.
really bad about that sort of thing. Yeah, no, for me to even be talking about it this far in advance is really good. So I'm making progress.
At least you're thinking about
Yeah.
it. Yeah, all right. So the plan was maxillary interferences, and we got some emails about this a while back. And then we were talking ahead of time, and it seems like when it comes to interference management, which we've discussed on here a couple times, I don't know if we'd explicitly had it as a topic of interest for the entirety of an episode, but it seems like feedback from working and talking to other people that people do this differently, or sometimes people don't really focus on it at all. Has that been your experience?
Yeah, I mean, I remember I think fellowship getting to the point of relieving interferences in the maxilla to determine the vertical position, the correct vertical position, or interferences in the proximal distal segment in the mandible. I used to hate those steps. They just seem so tedious and relatively without direction. Like we would just go after things, and I feel like my level of understanding at that stage was very much like I wish I didn't have to do this. So with time though, I think I've come to appreciate those steps as kind of some of the more important steps of the operation.
Definitely. I would throw it up there. I forget who told me, or it's probably been said different ways by different people for generations. But in surgery, I was always told, if you're doing something as far as your steps, it's either got to make subsequent steps easier or it's got to like accomplish a specific goal. And I think this falls under that category of it's not always fun. You don't always understand it as a resident looking at it, but it's one of those things that if you do it well, from that point on, like the rest of the surgery is just easier. Like trying to fixate with interferences, trying to put things in the right place without having relieved interferences, trying to be accurate without having relieved interferences is just so much more difficult. When I first got out of training, I can remember maybe neglecting these steps, not intentionally, but like looking back on it, it's like, man, why was fixation so difficult, especially like in the mandible uh, at times? And it's like, man, if I would have just spent 5 more minutes or maybe even less removing interferences diligently, it probably would have saved me 20 minutes or, sometimes more when it got to the subsequent steps. And so I think that's a thing that sometimes you got to slow down to go faster. And I think this is one of like nothing epitomizes that more in jaw surgery maybe than this.
Yeah. Yeah, there's some offsets on this. I will put a plug for custom plating when it comes to interference management. There's good data, and it makes sense that there is less removal of bony interferences if you are not using occlusal splints for your intermediate or your final occlusion. So whether you're doing, let's just say, maxillary surgery first, and you're positioning the maxilla based off of positioning guides and not the mandible, you have less interference management. That been your experience?
Can be. Um, Hold on.
You're getting a phone call.
Yes. So I'm going to shut my door here.
That has to do with obviously what you're doing. That case that you had up before you got rid of your desktop had to do with bringing a maxilla down, and in that situation there's not going to be any interferences to speak of, assuming you aren't moving it backwards. But in general, the philosophy of non-occlusal based maxillary positioning has to do with you're not dependent on the path of rotation of the condyle, right? So if you have the maxilla secured to the mandible, whether it's in your intermediate or final position, you are swinging the maxilla on an arc that results in it bumping into stuff more.
Yep.
And that isn't just hypothetical. That's just like how that stuff works. And so it depends on how you're moving things. So like moving a maxilla back when you're using occlusal based guidance is an interference party. Interference party, I use that term with my surgical team, and actually in my notes to myself. Like I'll make notes to myself before surgical cases, and so during the surgery I'll say, left maxilla is going to be an interference party, just because of the expected bony interferences that will need to be relieved ahead of time. And so on the plus side, I think custom hardware can help minimize those. I also have no idea how they can detect interferences. So while it's good that there's less interferences, how do you know they're happening without haptic feedback of it? You know what I mean? Like, it's the planned interferences if they're really heavy or obvious, but if they're relatively light, like a lateral wall bumping into your maxilla, or um, like a posterior wall of the maxillary sinus bumping up against the buttress, it's really hard to detect those. And interferences fundamentally will put your maxilla into a position that you didn't intend them to be. So if you can't pick up on them, they'll either leave it too long, shift it off to the side. I think what I struggle with is just how they determine it. And I do know that to be a problem when it comes to custom hardware. It's one of the inaccuracies is it's hard to control things like pitch because it's difficult to determine where the bone's bumping into.
Yeah, I have so minimal experience with custom maxillary hardware in this implication that I can't speak to it, but what you're saying makes perfect sense. And that wouldn't be one of the things that I was gonna to add or ask you if you had experience using custom hardware in this regard, because it does seem like without a limiting arc or movement pattern of any kind, that you could potentially have a little bit of a different scenario with that. And then the other question would be, well, how much does that matter if you have really thick custom hardware that does its job and you can put the maxilla in the right place and it's a little bit off and you did maxillary surgery first and then you do the mandible, are the differences big enough to get upset about? I mean, I think it would have to be midline discrepancies or, like you're saying, some pitch stuff. I mean, I don't know. I mean, how much does it matter?
Not belaboring the point on pros and cons of custom hardware or printed hardware or whatever it is.
Sure.
Um, I think the trying to recreate your surgical plan as accurately as you can uh, will definitely involve getting rid of interferences. So
Sure.
rid of bony contacts that cause a shift. Because maxillary ones are tough. I think if you start with maxillary first surgery, it makes up for some troubles. But for us mandible surgery first surgeons, it'll lead to a final occlusion that's a little bit off. So I I'm strongly of the opinion it's the most common way why maxillary mandibular midlines are misaligned post-op. That's not always true, but it's generally true in that you didn't quite detect that correctly, right? Like you had a shift. Um, and the idea of just like having your assistant push the chin up as hard as they can to where you hold the maxilla and put plates on the extreme, pushing as hard as they can, you can distract the condyles, but on the other extreme, not hard enough, then it can set it a little bit low and be off from side to side because you are seating two condyles, and a little bit of one side being seated a little bit different than the other can throw things off. And so my
How do you
goal,
do that? You got any tricks on that? Because
well,
I
that's
think
what I
that
was gonna say. My
takes
goal
reps.
is ideally to have as good a contact as you can because I think interference isn't just like let's get rid of them so everything is in the perfect spot. You also want to have pretty good contact, right? Because if it's because I've had those times where it's like if I hold it this one way, it looks good. But if you push it with like another Newton centimeter of force, or if you don't push it quite that hard, then all of a sudden it shifts like 2 millimeters, like that's not a really reasonable
Stable.
position to
Right.
expect your assistant to hold the maxilla to. And so I mean, I think part of it is kind of like intelligently, or at least like having at least a plan so that you end up with as solid contact bilaterally as you can. Because I mean, then it has to be better for healing, but it's definitely better for holding it while you put fixation on, independent of
Right.
what you decide. So I think interference management's like one of those that it's a bit hard to describe, and you get better at it with technique. Um, but I mean, in your normal case, let's say you're just doing an MMA case, um, where are you thinking about in terms of maxillary interferences?
That, you just kind of read my mind. I was going to say, do you want to pull up, do you have an image to show us, or do you want me to
Yeah, I
pull up
do.
an image?
Yeah, I just have a
Because I
3D.
think there's some definite common places that you have to look at, and then it's plan specific after that, right? If you're doing counterclockwise rotation, you're probably not going to have a lot of interferences posteriorly, and you're going to have more anteriorly.
This is just totally straightforward MMA. Don't worry about what's happening in the mandible. But maxillary interferences, I would say first off, do you use your plan to guide you, or
Yeah,
do you just always attack the same spot?
both. So I
Did you
definitely,
say both?
uh, yeah, which
Okay,
is,
I'm in.
yeah,
Go
I'm
for it.
trying to throw you off.
No,
So
I know. I wasn't ready for you to say both, but go for it.
yeah, keep you on your toes. So there's certainly places that I think as part of your plan you reduce every time. So for me, that would be you take your septal osteotome and you do your septal osteotomy before down fracture, and then I remove whatever if there's anything left on the septum at the in the coming down. I remove that with a Rongier, and then I
Above
group
or
it.
below? Because that's the other thing. Where do you find yourself removing interferences? On the mid-face side or the teeth side? Or does it even matter?
So for the septum, I'm talking about for the septum.
Yeah.
So I groove out on the nasal floor. So I remove any residual bony septum that's attached to the nasal floor,
Yeah, yeah.
and then I groove that out with a pineapple burr, ovoid burr, whatever you want to call it.
Yep.
So I do that pretty much every case. Like
Sure.
that's just something that's just done. That's part of the steps.
That's a good
It
spot to get bone. Like it's like clearing
yeah,
out
exactly. And then
talar
I keep
rim.
the
This is just bone
bone.
graft city. Yeah.
So I keep that bone in case I need to use it other places if I'm doing segmental surgery or other things, just in case. So I do that routinely. And then the other place is the lateral nasal walls that I pretty much
Yeah.
just take those routinely. Like
Yeah,
those,
those don't show up on the imaging much, but you just take the lateral nasal walls on the maxilla, not on the mid face component.
exactly. Yeah,
Got it.
take those. So routine, like that's those two things for sure. Every
So you're taking
case.
down this thing.
Yep.
Got it. Lateral
All the
nasal wall.
way all the way back to the vessels, which then I mean doing this all with a Rongier so far. And then when you get to
You,
the vessels, what I was trained to do was still use the Rongier, but you don't squeeze. So
your
like you'll
pronunciation, Rongier, I think you're doing it different just to mess with me. But keep going. Keep going. I'm finding it distracting, but
the
continue on.
rongeur, the rongeur. When I use the rongeur, then the way I was trained was what they called an open beak technique. So you put it and you squeeze it enough that you can move the rongeur. back and forth to free up and move that bone, but you're not squeezing it down to break it like you are pretty much everywhere else. Do you know what I'm saying?
Yeah, because you're talking largely up to now about just mobilizing the maxilla, right? Or are you
Yeah.
talking about for interferences?
Both.
Okay.
So usually what I would do is partially down fracture the maxilla.
Yeah.
Do you want me to say maxilla or do you want me to say that different too?
You could go Magzilla. Is that what you do?
Do you want me to go full? Do you want me
GGS?
to go full Southern? I'll go full Southern here if I
I'm
need
in.
to.
Go.
So yeah, I tend to partially down fracture the maxilla, and then I start kind of removing. I do that, and then I start pushing the mucosa up, like the nasal mucosa up more. Do you do the same thing? Like
Yeah.
just trying to avoid tears. Like I partially
I
down
mean, I
fracture,
like
take
what
the
you're getting
free.
at in that interferences in the maxilla are three-dimensional. I mean, I agree
Yeah,
100% because what, like as a resident, I was like, I got to cut here, I got to cut here.
right.
I'm basically just trying to reposition it. I mean, this sounds bad, but I really didn't think too much about interferences of the pterygoid plate as you're widening the maxilla, right? Or like the
Okay.
palatine bone or, lateral nasal wall. I mean, now I obviously appreciate that, but I think you're right to point out that this is more than just anterior maxillary wall interferences.
Oh, definitely. And I think that's often I tend to not focus on that as much because I know I can fix that in real time, like I'm going to be measuring,
Yeah.
unless it's a big one. Like if it's my rule is generally if it's 4 or more millimeters, then I make two horizontal cuts. Do you do
Yeah,
something
you're
similar?
crazy. You're crazy.
You don't do that?
I don't do that, no. But I mean,
Yeah.
that's fine. But yeah, I
Keep
mean,
trying.
when it comes to relieving interferences in back, I think that's um like from this perspective, I think this is an easy one that you may not realize what you're doing, but when you're freeing up a maxilla, getting the posterior maxilla free enough to where it passively fits in the splint is really just interference reduction, right? Like you're because it's really easy for this aspect to get caught onto a plate because it isn't that this is how the cut actually goes. Like it may go right here, right?
Yep.
I mean, if it goes here, it's going to be different. It may go back this way. And so how those things play out back there are a little bit hard to plan. I mean, the good news is in most cases with MMA, you're doing counterclockwise rotation, so your movement is moving away from that area. But even with the transverse, if you have a big transverse, you'll definitely bump into things. So I like that. I mean,
Yeah. Do you do that? Do you kind of do similar? And then I
yeah,
then I
no,
guess to
absolutely.
finish it off. And
Yeah,
I guess
sorry to
to finish
interrupt
it
you.
off, the other thing I take into consideration at that point is the nasal. We don't want to get into this too much. This is probably a future episode, but like the ANS, like if I'm going to reduce the ANS, that's when I would typically do it too. Like I've got the rongeur
You're
out and
crazy.
I'm already taking stuff away, so I would clip the ANS if I was going to do that at that point. If I didn't do a subspinal osteotomy,
Yeah.
if I did subspinal, then I would when I'm burring out the the septal groove on the nasal floor, I would then reduce a little bit along the subspinal osteotomy site to allow that to change position as needed. Is that kind of what you do for that?
Yeah, I mean, generally, with interferences at the nose, I mean, because the nasal tip can change, the septum can change, those interferences are a little bit hard to pick up on. Obviously, they can change for other reasons, but if we're moving his maxilla 5 millimeters, we're gonna have to reduce this to some extent, right? Like, and then with different movements like clockwise rotation, bumping into things in a different way, would obviously change it, but it's the same philosophy, which is, where are those bones running into each other? So yeah, I agree on that totally. Um, are you
The other,
biased towards one side or the other? Like doing
and
the maxilla side or the midface side on interferences?
I tend to do more when I'm doing it posteriorly. I guess I tend to do more on the maxillary side almost everywhere except anteriorly. Because I want to leave room for fixation and not get into roots and other things like that. You know what I'm saying? Am I
Yeah, I
making
mean, generally in the back part, taken away superiorly, you start getting into IMAX territory with some
right?
trouble. That's pretty easy to get into. So it's nice to.
But I tend
avoid
to
that.
do the maxillary side. I tend to groove out the nasal septum unless it's an extreme impaction. Then I would also go take from the septum itself, like, free up
Yeah,
the mucosa of the septum, take that away too if it's an
sure.
extreme impaction. Otherwise, I would just I tend to have when I do my septal osteotomy, I would love to say that I'm perfect every time and I cleanly strip the entire septum from the nasal floor, but there's always little pieces left. And I think between removing that and grooving out the the groove there, that I basically 9 times out of 10, if not more, create enough space to avoid septal interferences.
Yeah,
But if it was extreme, I would free up and I do this if they have deviated septums or if I need to do something else too, free up the nasal mucosa on the septum and trim the septum away, the bony septum away.
yeah, that
Residents, make sure you leave at least a centimeter anteriorly and posteriorly to avoid saddle nose deformity and other things. Um,
I
and
think
then,
oh, go ahead, go ahead.
and then the other area I typically always remove is can you turn that basically from a sagittal? Yeah. So basically, kind of the above the molar there. Yeah, like right from that point going posteriorly, I tend to take the rongea and just like clip off a big chunk of that. Um,
Yeah, I mean, there's some spots that I spend more time on than I used to. And posterior maxilla is definitely it, but this posterior lateral maxilla, because
yeah.
it just seems for whatever reason, this part seems to have a bit of
Yep. I take that
a
away.
fin of bone back there. And I
Uh,
mean, not always, but it definitely can happen. And clearing that thing out, because a lot of times it's like this weird, like little lip, and especially when you widen the maxilla, so like when it's here it's like no big deal, but then when you widen it you then bring out like this height, you know what I mean?
100%. Yep. So
So
you said it, and I think the other key component there is that it can be so thin that makes it one of those harder to detect interferences where there's like a subtle slide or shift, or
yeah,
you don't in your plan, you're thinking, oh, I'm advancing and this won't be an interference, or I'm widening and this won't be, but it always tends to kind of be there. And I don't feel like you need it.
yeah,
So I almost
'cause
always remove that unless I have some weird reason not to. And honestly, I can't even think of the last time I didn't.
yeah,
So I
give
kind of do
yourself a
that.
little room.
I take the septum, spine if needed, take the lateral nasal walls, move bone around the vessels, and then I take that posterior lateral maxilla above the molars or just distal to the molars. So that's pretty much what I take standard to answer your original question way back when.
You mean just dental distal, is that what you mean?
Yes,
Okay, yeah, all right.
posterior if you want to. Yeah, posteriorly. And so then that's pretty much what I would do standard. Like on almost every case, I would do that. And
Sure.
then that's when and you mentioned, the plan versus do I have just standard removal? So that's kind of my standard removal. And then beyond that, I would go to the plan to see if I was going to do anything else. And so that's where I would say for me, if I'm impacting more than 4 millimeters anteriorly, I make two horizontal cuts. I take a ruler, like the little caliper, and I make some marks, and I generally underdo it. So I would maybe aim for 3.5 to, width of the saw blade and error. Make two cuts, or you can remove it with a pineapple burr or a raw or whatever.
I mean, even if you're moving a maxilla like 8 up, you're going to do something else, right? Like this is an argument against that, by the way. So,
Yeah,
because
let's
you're
hear
going to
it.
change the pitch or you're going to advance it to some extent or move it back. And you're removing things that you could, in theory, at least get fixation into. I mean, getting positional screws into a maxilla is nice if you can pull it off. And a lot of times if you're not widening the upper jaw, the taper is such that if you just straight impact, you almost lose contact there. You know what I mean? Like it starts telescoping on the inside.
Right. For a
And
big movement.
so, like taking out more bones, so that's accentuated. It's like, well, if you need to, that's fine. But I don't, you know what I mean? I think
Well,
that's,
think about your plan though, right? You're doing counterclockwise here, right? So I mean, even if you weren't advancing a ton, when you add in that counterclockwise rotation, that anterior wall is still going to hit that mid face.
yeah,
And so,
because he's gonna hit like where these spots are. Because I'm a little prone laterally, by the way, like when we're positioning the maxilla. So we got the maxilla mobilized. We have the interferences in the posterior addressed and in the nose addressed. Um, I'm a little partial in an MMA case like this that is lateral nasal wall, like it's right there.
Yeah. Yep.
And then on the lateral, I want to take out above. Um, because here it's always like somewhat close to the molars, right? And I know that
Right.
in this situation, let's say the left side, we're up on the buttress, but maybe your cut actually is a little bit lower because you work with residents and you know how those. No offense, you guys. Anyway, the cut location may be a little bit different. It always tends to be a little bit too low rather than up because the masseter attachment's kind of like limiting your dissection, right? And so generally speaking, laterally, I kind of like removing here and even notching in this area and then taking out the lateral nasal wall on the maxillary side. So the interferences to impact, it's generally like this stuff,
Yep.
like
Right
this
there.
stuff,
Yep.
and then the north side to whatever is hitting this area. You know what I mean?
Yep.
Especially with going laterally.
So that's what I take off with a rongeur. And then I
Yeah,
even where you marked anteriorly, like when I'm removing the lateral nasal wall, I specifically clip that area too at the very anterior, like
these
right
guys.
inside that. Yep, right inside that anterior wall.
Yeah. Because I
Clip
mean,
that.
it's on those spots, it's just easy to get like a little ramp, and then you're holding the maxilla and it holds right here, but then as you push on it, this thing wants to move on you. You know what I
Mhm.
mean? So
Yep.
if you can get some bit of even contact and it's a stable contact, I think that's worthwhile. Clockwise, it's the opposite problem. You almost don't need to do anything in front. It's all in back. And posterior interferences are just kind of something you got to get over being scary. You just got to get rid of pterygoid plates. And so using your fingers and um, managing those interferences, because like if you haven't yet, the reality is that people do need their maxillas moved backwards from time to time. That was something that I had learned was never the case, but it does happen. And when you're in that situation and you need to move maxillas backwards, being comfortable with removing interferences is very helpful. So,
What
uh,
do you do anything differently than what I do? I mean, I know you do it worse, but like like
yeah, just worse.
specifically anything you go about differently?
Generally, no. I mean, because it does depend on the situation. Like in MMA with counterclockwise rotation, if posterior nasal spine is staying in the same spot or moving down, that'll give me some good indication that I won't have to do that much in back, especially if I'm not managing transverse. If the opposite's true, if I'm doing clockwise and retraction, like moving them back 4 or 5 millimeters and doing 4 or 5 degrees of clockwise, then it's going to be the opposite. I'm basically, even before I put them in a splint, I'll just take away as much back here as I can. Um, and oftentimes I even check that while the maxilla is free. You ever pull that move off?
Say that again. When
You
the
moving
maxillary spring, you're
maxillas
doing what?
backwards often? Are you moving them back?
No, not often.
Uh, so while it's still mobile, before you put it on the mandible, you can feel where those interferences are in back. Like just hold it and then, like set it backwards or pull forward, and see if there's like little distal interferences, like little segment of posterior maxillary wall or little plate or something like that. Because those interferences are much easier to access, just like in a class 3 situation in the mandible. It's much easier to relieve lingual plate interferences before you have them into the splint than it is afterwards. Um, because once you've wired the maxilla into the mandible, you're now limited by their mandibular movement and you're on the path of rotation of the mandible. And so I think if you're expecting heavy interferences, particularly posteriorly, managing those before you put them in the final or the intermediate splint is the right way to go.
For sure.
I don't know if that's that useful of a tip, but it's one of those tips I wish I at least had internalized before trying to figure it out on my own. But yeah, interferences. I think there only tends to be a few spots for those, and every once in a while you got to do a ton of them. But generally, kind of a directed approach at those different locations is really helpful. So
I forget where I've read this, But I remember reading somewhere in an OMFS text about orthodontic surgery that the author, I wouldn't say advocated for, but definitely mentioned, and I thought it was a good thing to read because I hadn't considered it before, and I don't know that I do it often, but I was going to ask you if you do. Is the implication that certain movements aesthetically or functionally don't necessarily have a big impact. So, like, let's say if you're doing a Lefort to only correct the transverse, but if you moved it forward 2 millimeters, the aesthetic impacts of that would be minimal. Maybe not even perceptible, but you maybe move in the AP or another dimension to help prevent or eliminate interferences because there's not a perceptible change. So, like, hey, if I move the maxilla forward 2 millimeters, that'll help me with interferences posteriorly. So I'm going to just do it because it's an imperceptible change. Do you take that into account with your planning, or has that ever crossed
Yeah,
your
and
mind?
I feel like that's what planners commonly do. They're like, oh, we'll just plan to clear the plates and we'll plan for contact. And what they're saying is we're going to scoot you forward a little or we'll scoot you up a little bit. Um, they're just not using necessarily the words, but I think there's definitely wiggle room in most plans, right? Like there's some things there's not much wiggle room in, like occlusion and midline. But in terms of AP movement, there is. Vertical there is. So I think cheating to help yourself out is a good idea. It's like setting yourself up for success is good. I think hard ones are just like the mandible is just big asymmetries, or you're moving in extreme dimensions, right? Trying to get the bone in contact on either side and not spend too much time on that is a good goal, but sometimes it's not even achievable with the little cheats that we have. So but I think it's time well spent. Interferences are important. So I think getting the
Definitely.
final bite correct and the final result, independent of the fixation type, is good.
For
So
sure. All right.
kind of a quick topic today. I like it.
Yeah, I thought we nailed it, to be honest.
Well, I'm glad you're feeling good about it. I mean, we both shared screens, which is nice, and then we did alternative pronunciations of common words. This is a really exciting episode, I thought.
Yeah. 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 Yeah.
Next week, we have a guest, so it'll be a good one. I'm looking forward to it. But yeah, thanks for chatting today, man.
Yeah, thanks to you as well. And that was another Down Fracture podcast, a podcast for talking jaws. Downfracturepodcast at gmail.com. If you want to send us some anniversary wishes or gifts, money is always appreciated. Anything, gift cards, Amazon gift cards. You shop at Kmart a lot? Is that what you were saying? Like, what do you
I
get at
just generally
Kmart?
don't shop. I just like hearing from people. So
Hmm.
send us a gift of like a case or something you want us to talk about. That'd be sweet.
And money. All right. Well, don't, um, whatever. Don't judge me.
All right.
Only God can judge me. All right. Well, till next time. See you, Sam.
All right, man. See you.